Just a reminder of artery structure. You've got the endothelium or the tunica intima. You've got the media, which is where the smooth muscle is, and you've got the outside of the arteries where it's made up of collagen and elastin fibers. The important piece of the anatomy that keeps the homeostasis going in the body is that tunica intima, the endothelium. This is where food and oxygen is allowed to pass into the tissues and where waste and carbon dioxide pass from the tissues to the blood. When there is damage to this smooth lining of the interior of the arteries, it can create clot formation to occur, and this is also where plaque builds up on the interior of the arteries. Lipoproteins. So when we're talking about lipoproteins, the major rule here is the more protein gives you the higher density, and the more lipid gives you the lower density. So high density or HDL lipoproteins are the good ones, and the LDLs are the numbers that we want to see going down that indicate disease. And you can see that the triglyceride levels are also elevated in LDLs. Hyperlipidemia is where you have increased lipid levels in the blood, triglycerides. Generally, the people at risk for hyperlipidemia are those that have a genetic predisposition. But as you can note here, nutrition, obesity, sedentary lifestyle, smoking are all indicators or are all variables that we have some control over. So know that we can impact hyperlipidemia in a positive way by improving our nutrition, decreasing obesity, and having exercise in our lives. Hyperlipidemia is diagnosed by having high LDL levels, and the treatment is aimed at reduction of the LDL cholesterol, dietary restrictions or modification, exercise, definitely smoking cessation. Hypercholesteremia is an increased blood cholesterol. Again, same damaging factors, same modifiable risk factors. Should we not fix our hypercholesteremia or hyperlipidemia, we are at risk for developing atherosclerosis. As we get older, this is just one of the things that happens, but males are typically more at risk than females unless the woman is after menopause. Again, the same modifiable risk factors: smoking, obesity, hypertension, hyperlipidemia, elevated LDL, elevated cholesterol, and diabetes. What happens here is the white blood cells initiate an inflammatory process, which in turn promotes plaque formation on that endothelial lining, and those plaques end up blocking the arteries as it progresses over time. The signs and symptoms we see are as a result of the narrowed blood vessels creating ischemia, emboli, and obstruction in the arteries supplying the heart, brain, kidney, and lower extremities. The plaques that develop on the internal arteries can either be classified as stable plaques or unstable plaques. In a stable plaque, there's a very thick fibrous cap, and the vessel becomes basically partially blocked because of these big caps. In stable plaques, they do not have a tendency to form clots or emboli, so the risk of stroke related to emboli is not a problem. But sometimes we form unstable plaques, and these have very thin fibrous caps that can rupture. And when they rupture, they can cause a clot to form, and this clot can completely block the artery, or it can break free and become an embolus. And this is one of the major factors in ischemic strokes that we'll learn about later on this semester. So coronary artery disease creates a risk of over 250,000 deaths per year, mainly affecting white, middle-aged, that means over the age of 60, males. Coronary artery disease has a direct relationship to atherosclerosis, and what coronary artery disease does is, because of these atherosclerotic plaques, the body is receiving a loss of oxygen and nutrients to the myocardial tissue as a result of the poor coronary flow. The onset of coronary artery disease occurs over time, and that's what makes it kind of silent in its outbreak. Coronary artery disease has a progressive onset over time. It's kind of a silent killer. So we generally don't start implementing the modifiable risk solutions, such as changing our diet, increasing our activity, until it's too late and that we are already in full coronary artery disease, where we are getting transient ischemia causing oxygen deprivation. Eventually, if untreated or the disease progresses, it can result in a decreased cardiac output. We generally diagnose this through changes in the EKG, generally in the ST segments, and coronary angiography, which is a intervention that we do to take a look at the arteries of the heart and how much damage has occurred to them. Coronary artery disease presents itself with chest pain upon physical exertion, and we treat it by rest, by giving nitrates so that we can improve the oxygenation and open up the arteries as wide as possible. As the disease progresses, we may need to implement a more permanent solution by opening up the arteries through a percutaneous cardiac angiography and inserting a stent so that the arteries will stay open. Or last but not least, we may actually go in and do a coronary artery bypass graft, where we take pieces of vein from the legs and recreate new arteries in the heart so that we can get oxygen to the heart tissue. Another coronary disease that occurs is peripheral artery disease. Same reasons, a systemic atherosclerosis, same risk factors, but please note that smoking and diabetes are generally the most significant risk factors that are included in coronary artery disease and peripheral artery disease. Again, the signs and symptoms of peripheral artery disease are gradual and progressive. You get intermittent claudication or pain in your calves related to exercise. There's muscle atrophy because of the resulting lack of use and the decreased blood flow. And extremities become cool, bluish in color, and have very weak pulses. Diagnostically, we use ultrasound imaging and eventually MRI and arteriography to progressively diagnose what's going on in the peripheral artery disease. Treatment involves lifestyle changes, as we've talked about before, loss of increase exercise, decrease weight loss, or increasing weight loss, and eating the right foods. Because the peripheral artery disease is permanent, unless there's some sort of an arteriography that takes place, a fempop bypass, where we've established the blood flow to the lower extremity, injury prevention is very important because once the individual has injury in the foot or lower extremities, it's very hard to get the healing process to take place because of the lack of blood flow and oxygenation to those areas to support proper healing. Aneurysms are abnormal localization of a blood vessel resulting in a dilation. 95% of them result from arteriosclerosis, They can be found. What it actually does is the wall of the artery weakens and stretches, and there's a risk of rupture and hemorrhage and clot formation in the area where the blood pools. Aortic aneurysms can be the most deadly. They can be found either in the thoracic cavity or the abdominal cavity, with abdominal being most common. And many times these are asymptomatic. They're found on a regular physical assessment where you can feel a pulsating mass in the abdomen, or they're found incidentally when the client or patient is getting a CT scan or an MRI and it's visualized. Signs and symptoms of a rupture or a leak generally are weakness, sweating, tachycardia, and significant hypotension. 20% of the ruptured aneurysms die immediately from the shock resulting from the massive blood loss. In terms of treatment, we generally want to graft or stent these abnormal stretches of the artery, and we also treat them with beta blockers to reduce the blood pressure so that we can minimize the effects of blood pressure on increasing that stretch. Cardiac tamponade is a situation where there's a reduced cardiac output because of inability to fill the ventricles. It is an emergency situation, and cardiogenic shock and death can occur rapidly. Cardiac tamponade generally happens in response to some sort of trauma, such as a gunshot wound or a stab wound, but can also happen as a result of effusion and coagulation issues that one might have related to cancer treatment. The signs and symptoms are hypotension with a narrowing pulse pressure, neck vein distension, muffled heart sounds, and diaphoresis. We usually diagnose this on chest x-ray. The EKG will also show changes in the QRS size being diminished because the ventricles can't contract significantly, and ST elevation on the EKG. We treat this through needle aspiration or surgery, and we support the blood flow of the body by using inotropic drugs such as dopamine. Hypertension or high blood pressure is caused by an increased cardiac output and increased peripheral resistance, or both of those. We see this most prevalently in men, those of African American descent, lower socioeconomic groups, and the elderly, because of that hardening of the arteries that naturally occurs as you age. Hypertension can be classified as primary versus secondary. Primary meaning there is no cause, it just is, or secondary, there's some secondary disease process that's creating the hypertension. In 2017, the parameters for what we consider to be diagnostic for hypertension changed, and what that means is the systolic and diastolic readings classifying someone as having hypertension got lower rather than higher. Again, there are, this is a very common disease process. There are modifiable and non-modifiable risk factors. Modifiable meaning diet, exercise, salt intake, weight loss, alcoholism, and non-modifiable genetic or family predisposition or age. You will have to memorize the ranges for what we consider prehypertensive, stage 1 and stage 2. Please note that prehypertensive, the diagnosis is made when the systolic and diastolic meet these parameters, whereas stage 2 and 3, it can be either the systolic or the diastolic parameters that are changed. But the most important thing here is this used to be pre-hypertension used to be 129 to 139. It is now 120 to 129. So that's a significant change in diagnostic parameters. And what we've learned is we need to diagnose this earlier and intervene earlier. Hypertension targets the same disease, the same organs as diabetes does. It targets the kidneys, causing nephrosclerosis. It targets the heart, causing congestive heart failure and heart arrhythmias. It targets the eyes, causing damaging the retina and causing blindness. In the blood vessels, we know that there's damage and hardening of those major arteries, and in the brain, we can see a resulting stroke. The mechanism of action that happens is hypertension increases the workload of the left ventricle, causing potential hypertrophy, which then causes the arrhythmias and the CHF. Basically, your heart becomes weaker and unable to circulate the blood through the body because all the arteries have hardened so much that it takes more pressure to push things through. Last but not least, there's a disease called pre-eclampsia or eclampsia that you'll study more in your second semester OB class, but know that this is a result of acute onset of hypertension during pregnancy. It is considered an emergency situation, and it is considered to have significant harm on both the mother and the baby. I won't test you on this, but you will see this again. And just know that eclampsia is hypertension during pregnancy.